this lesson is going to talk about pressure ulcers. Now, this is a hot button topic in the hospitals because it is hugely preventable. If your patient does get a pressure ulcer while they're in the hospital, that's called a sentinel event, which means the hospital does not get reimbursed for that patient's care. Not only that, we've now exposed the patient to a wound, risk for infection, and a prolonged hospital stay. So it's really not okay. So we want you to know what to look for and how to prevent this from happening to your patient. So you may already know some of this, but let's review. A pressure ulcer, also called a bed sore or a decubitus ulcer, is a wound or ulceration caused by prolonged pressure on tissue. The longer that its pressure is there and the more the pressure is, the more severe the wound is going to be. Think of it like we're in a path, like a walking path through the woods. The more people that walk along it, or the more often it gets walked along, the more the grass dies and it becomes this dirt path, right? So the more pressure and the longer the pressure is there, the more degradation of that tissue happens. Problem is, the evidence shows this can happen with just like 2 hours of pressure or less, which is really scary. Now, the most common areas for these to form are going to be over bony prominences like the sacrum, the hip bones on the sides, the elbow, the occiput. This is when people miss a lot. They forget to look at the back of the head, as well as the heels. Those are the most common places that we look. Basically, any bone that sticks out or any place that has prolonged pressure on the bed. The other place that's really common is under devices. So things like a nasal cannula can cause pressure on the nose, but also on the ears. So where it comes up over their ears on the side, it can cause a pressure wound right there. So those are things to think of if you've got devices. A Foley catheter. I have seen a Foley catheter cause a pressure wound on a leg because it was pushing up against it and hadn't been moved. So make sure you're checking every single one of these sites. Check the elbows, check the back of the head, and check under your devices. Now, when it comes to staging, most facilities require a specialty training as a wound ostomy continence nurse or a specialty wound care training to be able to officially stage a pressure ulcer. And that is mostly for legal purposes. Because of the financial thing, they don't want you calling it a stage 2 when it's not. But we still want you guys to know kind of what you're looking at. So a stage 1 is an area of redness that doesn't blanch. When I say blanch or blanchable, I mean you push your finger into it and it turns white. So if it doesn't turn white, if it's not blanchable, that is considered a stage 1, okay? The key thing here is that the skin is intact. Stage 2 is partial thickness loss of the epidermis only. So you're going to see it's going to be pink or beefy red. You're going to have a little bit of loss of the top layer of skin. You might even have a blister, but it's a superficial wound. Now, stage 3 is full thickness loss of the skin, both the epidermis and the dermis down into the subcutaneous tissue. So that's as far down as you've gone. You shouldn't see any muscle or bone in a stage 3. And then stage 4 is the worst. You're going to see it goes all the way through the muscle and typically down to the bone. So you can see there's some bone here showing. I have seen stage 4 ulcers that I could put my head in. It was awful. You can stick your whole fist in them. They're really, really bad. Now, one thing to note in both stage 3 and stage 4 is you might see this yellow substance. It's called eschar or slough. And that is just dying tissue that needs to come off. The other thing in stage 4 that you might see is undermining. Undermining is when you start seeing the edges roll. So under here, under the edges, it's actually their wound goes farther than we think. So if this is the wound edge, this is what we see, but the wound actually goes out to here. That's undermining. The other thing that we could see is tunneling, and it is exactly what it sounds like. There's a tunnel. And so right here is a good example. I could probably stick a cotton tip applicator in there, maybe 2 inches. It's deeper than the actual wound itself. Those are the tunnels. So we need to make sure we're assessing those when we see pressure ulcers as well. What do we need to do as a nurse for patients who are at risk? Well, first things first, we have to assess our patient's skin. We do detailed skin assessments on admission, at shift change, and with every assessment. Now, this one's really important. At shift change, we usually will do 2 nurse skin assessments. So we put 4 eyes on the skin, confirm that we're both seeing the same thing, so we have consistency and documentation. We're also going to assess a Braden scale on admission and every single shift. The two biggest things that can cause a risk for breakdown are immobility and poor nutrition. And so the Braden scale takes those into consideration, as well as other things like friction and shear, sensation, moisture, etc. But these are the two biggest factors. So the lower the Braden score, the higher their risk. We've attached a cheat sheet to this lesson that helps you see that, has the Braden scale on it for you to look at. And now, as far as interventions, the most important thing that we can do for these patients is turn them every 2 hours or more often. And we usually use a turn schedule like left, back, right, back, or left, right, back, left, right, back. It just depends on your facility, but make sure that you're turning them. If they do have any red areas, we don't want to massage it. I mean, that's just more pressure on it, right? And we don't want more pressure. So don't massage it if it's red. Bony prominences, we want to offload off the bed. So we want to float their heels. We want to put their elbows up on pillows. Even the back of their head, sometimes we'll get a round donut cushion so that the back of their head doesn't touch a pillow or the bed or anything. Then we can also use specialty mattresses. We can use turn wedges, special pillows, things to keep the pressure off of their skin. We want to keep it clean and dry, and we want to make sure we call in consults to help us with everything else that we need. We want to consult our wound care specialist nurse. We want to consult our nutritionist to help us maximize their nutrition because, again, protein is really important for skin and wound healing. Now, if a patient does develop a pressure ulcer, we're going to follow the provider or wound care nurse orders. So make sure that you have wound care orders. They'll tell you change the dressing this many times a day, use this type of dressing, wet to dry, or to pack it with a certain sort of specialty dressing like iodoform. So make sure you see your orders, make sure you're following your wound care orders. Now, some patients, especially with the deeper wounds, may also get wound vac therapy, which is exactly what it sounds like. It's a vacuum, it's a suction, it's a negative pressure therapy for the wound. So they'll put a foam piece into the wound, they will seal it up with a plastic tape, and they'll attach it to a vacuum. And that helps to pull out drainage, especially infectious drainage, but it also helps to increase healing, and it increases granulation of the wound, which is a good thing. We want it to granulate. That means it's growing in and healing. And then some patients might need surgery. They need to remove the dead tissue, get it debrided, and they'll literally remove all of the dead tissue down to healthy tissue. So most of these patients will actually also end up with a wound vac. Now, obviously, tissue skin integrity is a top priority for a patient with a pressure ulcer, but I also included clinical judgment. Now, here's where I'm going to jump on my soapbox for a second. Guys, there is no excuse for a pressure ulcer. I have seen some massive stage 4 ulcers come from nursing homes that absolutely break my heart because they are a sign of neglect. We know they can develop quickly. We know that offloading bony prominences and using specialty mattresses, repositioning every 2 hours, we know they're preventable. So we want you guys to be a champion for your patients. We want our NRS&G family to be the best turners in the entire facility, okay? Turn your patients. Look at their skin. Just imagine it's your grandma in that bed. Take care of her and don't let anything happen to her, okay? Okay, that's it. Soapbox over. Let's do a quick recap. Pressure ulcers are wounds that form due to prolonged pressure. The more time or more pressure, the more risk for developing a wound. It can happen over bony prominences, under devices, etc. Now, pressure ulcers are staged based on their depth and the involvement of tissue. Just make sure you know your facility's policy because a specialty nurse might have to do staging. But obviously, the worse the stage, the harder it is to fully heal and the higher the risk for infection. Prevention is key here. There's absolutely no excuse for a pressure ulcer. So assess their risk with the Braden scale, assess their skin condition, again, on admission with every shift change and with every assessment, you should be looking at their skin. Now keep your patients clean and dry, fluff them up with pillows, offload those pressure points and turn them every 2 hours or more often. And if you need to, consult wound care, consult nutrition, make sure we're doing what we can to get those wounds healed up. Okay, guys, those are the most important things you need to know about pressure ulcers, not only to pass nursing school in the NCLEX, but to be a great nurse. We want you guys taking the absolute best care of your patients. So go out and be that nurse today. And as always, happy nursing.